Hello, Peter, and welcome.
Hi, Szabolcs. Thank you for the invitation.
Conference in London, Peter Legeza gave a talk about how to reduce by not less than 70% the X-ray dose related to digital subtraction angiography in lower limb interventions. In this podcast, we ask Peter about these results. Peter, why is reduction of the X-ray dose important in interventional radiology and in lower limb interventions in particular?
Hi, Szabolcs. Thank you for the invitation. So basically, there are several occupational hazards for the interventional physicians. Due to the radiation exposure, the interventional team has to wear personal protective equipment, such as lead aprons, neck collars, or protective glasses. However, despite these measures, radiation exposure is still associated with increased eye complications, such as cataract or cancer, especially in the head and neck region. The so-called LRA principles suggest to use as low radiation dose during the interventional procedures as reasonably achievable. This includes several intraoperative techniques which can successfully reduce radiation dose in any minimally invasive interventional procedures. This is a very important issue since the interventional team spends a lot of time in the angio suite and we have to avoid all the unnecessary radiation.
So what technology made it possible, this drastic reduction of the X-ray dose you talked about?
DVA imaging is an alternative imaging modality for conventional angiography. One of its advantages is to demonstrate X-ray dose reduction during angiographic studies. So far, we were able to show a 70% angiography-related radiation dose reduction with this technique without affecting the image quality. I think this is an amazing result.
How come DVA can reduce the X-ray dose this much?
DVA imaging is a special algorithm based on the statistical analysis of the image set. Instead of generating a summary of a time-resolved image series, as in DSA imaging, kinetic imaging algorithm uses the entire data set of images to extract the information of changes. It enhances the functional contrast media-related information and suppresses the noise-related information. This way, we receive an improved image quality, what we call a quality reserve. And this quality reserve is what we may use to reduce radiation dose or contrast dose during angiographies.
This sounds nice. How did you study the radiation reduction capabilities of DVA imaging?
Well, we wanted to see if DVA imaging can be used for radiation dose reduction in lower limb endovascular procedures. Based on our previous proof of concept studies, we calculated that a use of 70% dose reduction should be realistic in our study. In our vascular centers, we conducted a single-center prospective randomized control trial to demonstrate this capability of DVA imaging.
So what was the patient population you examined?
So in our study, we included patients with lower extremity arterial disease. They were planned to undergo lower extremity diagnostic angiographies in our center. Of course, patients with chronic kidney disease were excluded. Over the course of 9 months, we included 114 patients and randomized them into 2 groups. The standard dose group received a radiation dose consistent with the everyday standard of care in our institute. The angiographic studies in the reduced dose group were performed with a 70% nominal reduction of radiation dose.
Eventually, how many images did you analyze throughout this study?
Yeah, throughout the study, we examined 4 anatomic regions for every patient, namely aortoiliac, femoral, popliteal, and the crural arteries. In the standard dose group, DSA images were generated, and in the reduced dose group, we generated DVA1, DVA2, and DSA images. So altogether, based on that, more than 700 images were included in the analysis.
And what results did you find?
On one hand, we have seen a significant radiation dose reduction in the reduced dose group, of course. The total procedure-related radiation dose was reduced by 45%, while the angiography-related radiation dose was reduced by 63%. These results were quite impressive for us. And despite the relatively big radiation dose reduction, there was no difference in the diagnostic properties of the standard dose DSA and the reduced dose DVA images.
Well, what differences you find depends on how you analyze them. So how did you evaluate the DVA and DSA images?
Yeah, that's a good question. We have asked 6 independent vascular interventional specialists to review the generated DSA and DVA images. They were asked to rate the images on a 1 to 5 scale, 1 meaning the worst and 5 is the best. We have found that while DSA images created in a low dose setting receive significantly lower scores compared to the standard DSA images. This difference was not seen between standard dose DSA and reused dose DVA images. They receive similar scores in every anatomic region.
You mentioned 2 DVA algorithms, 2 DVA images, DVA1 and DVA2. So what are the differences between these two? And did you find any difference between image quality between them?
Yes, there are 2 different algorithms. Basically, they differ in the noise reduction capabilities. DVA2 is associated with the reduced background noise. Interestingly, we found that DVA2 images perform significantly better than DVA1 images in the infrainguinal region. When the observers were asked to tell their preference between DVA1 and DVA2 images, as moving toward the distal anatomic regions, they showed a tendency of DVA2 image preference. For us, this suggests that DVA2 has an advantage in the imaging of smaller vessels.
So if I understand correctly, you got scores for all these images individually. How did you analyze this data set statistically?
Well, we used the standard non-parametrics test in the analysis. Mann-Whitney test was used to compare the radiation dose between the standard dose and reduced dose groups. And Kruskal-Wallis and post-hoc Dunn test was used to compare the results of the image evaluation.
So this sounds very nice, what you told me. I assume some may want to try DVA. What do you need to change in the workflow of the operating room or in the image recording procedure if you want to use DVA?
Well, that's a pretty great question. Since DVA imaging is based on an algorithm which runs as a software, there are no instrumental requirements for using it. So far, we have tried the Kinepict software with GE, Philips, and Siemens angio suites, and it is compatible with all of them. When the operator performs an angiography, the software automatically generates DVA images, which pops up in the room's display and can be immediately used for operational planning or diagnosis. So the answer to your question is that you don't really have to change your workflow.
It sounds simple to do. I know of several technologies that help reducing X-ray dose, since we know its importance, as you highlighted in this podcast as well. Is there a way to combine DVA with all these other existing X-ray dose reduction methods, or do they exclude each other with some? So how do these add up?
As I mentioned, Kinepict imaging tool can be used in every standard angio suite. Therefore, all the achievable radiation reduction techniques can and should be used during the intervention. So there's no conflict between these radiation reduction techniques.
So what patient groups could benefit most from DVA imaging?
Basically, all patients will benefit from DVA imaging. Since DVA imaging reduces the potential harm for our patients, another important thing to mention is the exceptional image quality of DVA imaging with CO2 angiographies. This can be used in patients with reduced kidney function, so they are also a very important target population for this kind of imaging. And it is important to mention that besides these patients, there is a huge benefit for the physicians and the interventional teams, because their cumulative radiation dose is extremely important to reduce.
Thank you, Peter, for accepting our invitation to the Kinepict Knowledge Base podcast. And thank you for your contribution. Bye-bye.
Thank you for inviting me. Bye.